Thank you, Dr. So the next talk is going to be about balancing the valgus knee, and will be presented by Dr. Ahmad, who is the knee and shoulder surgeon specializing in arthroscopic and joint reconstruction in the المفصل.
Now moving for more advanced surgical technique. What about balancing the valgus knee? Before start, what would you do for this? This is a severe valgus deformity. She's an 80 years old. She has this gait and X-ray. What do you think? Who would do hinge? Who would do hinge prosthesis? Dr. Hassan? And anyone think that prosthesis can work in this case? Yes? Okay. Now, this is the X-ray, this is the bond defect. Now, when we are talking about this is a more difficult subject because surgeons are not used to deal with valgus knee, and they are less common. And also there is some difficulty in releasing the contracted lateral structures, not like the valgus knee, which you are used to do that. Now, what about the anatomy? We have a valgus alignment, and this is associated with bony deformity and soft tissue imbalance. And you see when there is a valgus, there is many of the time bone defect. There is lateral contracture with the soft tissue, and also there is laxity of the medial structure. Now, what about the bony deformity? It's not only bone defect. There is also external tibial torsion, and also there is patellomast flattening, and also there are a handful of foot deformity which will shift the mechanical axis laterally and making the problem more and more. Now, what about the soft tissue? We know that in the valgus we have a lateral contracture of the capsuloligamentus structure and also medial laxity, and understanding this mismatch between the medial and lateral is essential and very important when you balance the knee, because you will have balancing for the medial lateral and also in the flexion and extension. And to do that, we have to know the anatomy, because we know when there is tightness in extension, there is mostly a problem with the iliotibial band or the collateral capsule. But the lateral collateral and the flexious ligament, they can cause tightness in both flexion and extension. So this is important. Now we know the pathoanatomy, how we evaluate our patients. Because this is important. By clinical evaluation, you can decide the degree of valgus, the presence of ligamentous laxity, and the presence of sagittal plane deformity also. Now, as usual, we examine the patient standing and walking, and you see here, he has hyperextension beside the valgus. So this is what we call it valgus hyperextension deformity. And this is what we call sagittal plane deformity. So the evaluation also should include the patellar tracking, if there is tilt or not, and the status of the peroneum. Now the very important question, is this deformity is correctable or not? And this is first, we examine the patient for the medial compartment, and you see medial laxity. You see there is endpoint, and the deformity is correctable. Now, what's causing the deformity? Is it the medial laxity, or is it the lateral bone loss? This is very important question. So to answer this, we can do stress extent. So if you do stress reviews and there is no opening of the medial structure, so most of the deformity or all deformity is from the lateral bone defect. And you see here there is no opening, so this deformity is resulted from lateral bone loss. Now look to this case. There is laxity, medial side. Yes, there is no firm endpoint. And now, is it bone loss or medial laxity? We said you can do a stress review, but also clinical handling is that you do rotational stability. And you know, when we have deficient MCL, there is also rotational instability, not only medial or valgus instability. So this gives you a clinical hint, and you make sure by doing the X-ray so you can check for the medial laxity or the lateral bundle. Now, here in this case, there is significant medial laxity. Now, next step, we do clinical evaluation. Now we know about our patient. Now we have to have good imaging. Besides the routine AB and lateral view, you need always to have a long film. And this, you can see the hip knee, ankle angles, sorry. And also the mechanical axis. So you know the valgus angle and the mechanical axis. And also by the X-ray, you see if there is a bond defect. And you see here, there is a bond defect on the lateral side. And if you see the lateral view, there is a bond defect in the anterolateral side. So this is a valgus hyperextension. So by your clinical evaluation and imaging, you can decide what type of deformity you have. And we are not only doing stress reviews or weight reviews, we are doing deformity correction. So when we send our patient to the surgery department, we said, just make a sling and push against the deformity. So look for this case. It was here, you see the bond defect and overlap on the lateral side, and here it's corrected. So this gives you an idea about the normal joint line and also the degree of correctability or flexibility of the lateral structure. So this is the head. Now the skyline view is important to assist the lateral tracking because if there is lateral subluxation look like here, if you don't take care of that, you may end with real problem. Now, we have clinical and radiological evaluation. So by this, we know degree of the valgus and the site of the valgus. Is it the joint or the joint line deformed, or is it the medial laxity that causing the deformity? So the status of the MCL. And we also know about the flexibility of the lateral structures, and we check if there is combined surgical plane deformity. So now we can classify and plan the measure. Now, and this is actually our evaluation and imaging. This is the base for the classification system. Because look for here, runabout classification. This is based on the degree of the deformity, the status of MCL, and the amount of the lateral release required. And this is what we have just checked by clinical evaluation and imaging. And look here, this is very important classification because it gives you a guide for management. And if you see here type 1, it's intact medial. This is very important, intact medial structure. And there is not much deformity. The deformity is less than 10 degrees. So here, you can use normal implant. And you need only, if there is lateral contracture, you need only to balance with a normal MCL. So you don't need a lot of lateral. So this is the fact. Type 2, here there is attenuation of the MCL. The deformity is between 10 and 20, so it's moderate deformity. Usually there is no bone loss, maybe a little. But here, in this type, the MCL is attenuated, and so if you want to balance them, so you have to do more extensive lateral release. And in these cases, if you have such cases, you should be prepared for possible constraint damage. Because we have problem with this. If you do extensive release and you have attenuated MCL, so you have larger gap, larger polyethylene, longer operative time, and there may be a risk of peroneal nerve injury. So you have to be prepared for possible constraint. Now type 3, here the key point that the MCL is deficient. So in these cases, you cannot, whatever you do, you cannot balance the knee. So in these cases, you need a constraint or a hinge, like LCCK or a hinge implant. Now, what type? In these cases, when you have like excessive bone loss and exarticular deformity, what type of implant? Is it LCCK or hinge? And this depends on what? So there are more other modified classification, and this classification by Molaji, who took like the same types of runouts, but he added more subtypes. And again, it depends on the integrity of the MCL. And he added this type, 3 and 4, when there is intact MCL, but there is 5-planar deformity or 2-plane deformity, like flexion, contraction, or hyperextension. And in these cases, like type 6, for example, when there is extra-articular deformity, in these cases we have to be carefully deciding the type of implant. So this is here, type 3 and 4, and here how we choose the implant. Because we know the stability is going up from cruciate retaining, pseudo-stabilized, CCK, and hinge. So which implant for which need? So if you have like type 1 with deformity less than 10 degrees and the MCL is 10, you can use even the cruciate retaining. But if you have more deformity and between 10 and 20 and the MCL is stable, you can use pseudo-stabilized. But the problem, if you have the MCL unstable or deficient, whatever type of deformity is type 2 or 3, if it's deficient, you need a more constraint, so you can use the LCCK. But if you have multi-directional instability, like you have deficient MCL, deficient posterior capsule, hyperextension, excessive bone loss, so in these cases, you need a hinge implant. So what about the surgical technique? Which approach? Anyone using the lateral approach?
According to the case.
Because the most common approach used for valgus knee is the medial paralateral approach, and you can use the lateral approach for severe fixed valgus deformity or valgus with flexion deformity. This may help you. And also in cases where there is patellar dislocation or fixed patellar dislocation, this is very helpful to use the lateral approach. Now, you can expand the approach, and I think you may need this in valgus knee, and you can use either the quadriceps slip or tibial tubercle osteotomy. Now, this is an example of one of the cases, a patient with excessive bone loss and deformed tuber prosthesis. And you see here the osteotomy. You shouldn't make it long, good bone patches, and plan how you refix it, because the problem if it's adult. So what we do actually, that we put the circulage wires, sometimes you can use screws, and these circulage wires should go around the implant, because it may cut through, especially, like in this case, especially the first one, because if it's cut through, this is a big problem. And what I do also actually, I want, like, if you see the fiber tape, I do what we use in sports injury, like internal bracing for the tibial tubercle. So we pass this, I'll show you a video. Here the circulage, and you see how it go around. And what's nice here, if you need like proximalization of the tibial tubercle, like if you have patella baja. So in these cases, tibial tubercle osteotomy help you in the approach, and also help you to elevate the tibial tubercle up, proximalize, so this will improve your patellar fracture. So this is important, and this is a video. This is why. This is a very nice video showing how the internal brace become tight on flexion and loose in extension. This is protective for your fixation. Now, what about the soft tissue release? We need sequential release. You don't have to go direct or excessive release. You should have gradual step-by-step release. And we use side casting technique. And we have to remember that. This is very important. Which structure? Which release for what? Which structure will I release? So if the problem with the extension, so I have to start with the iliotibial band and also maybe the posterior capsule. But if it's inflection and extension, so I have problem with the LCL and completed. So you have to decide which, and also you may need to do lateral retinacular release for improving lateral traction. And I like to do lengthening rather than release. Now this is a technique very nice described by Manu, and this look how he do that by palpation, and you see how it's open. He palpates by the thumb, where the tight structure, go and do by clustering, and if you see when he did that, it's open, the tensioner is there and it's open. So this is very nice. This is a very nice slide. I found it in a webinar, I think in India. And it's described like a sequential technique, how you do lateral release. It's described by Ilkus, and it was published in the Journal of Bone and Joint Surgery. And what he do, he call it inside-out release. What he does, he first starts with the distal femoral cap and the proximal tibial cap. And after that, he do the balance at extension, so doing release laterally. And after that, when he has balanced extension gap, he make the posterior femoral cap after that, parallel to the proximal tibial cap. This is very nice, make surgery easier, but I think it carries the risk, like our colleagues mentioned, that if you make it, the tight structures laterally and you make like internal rotation to widen the lateral gap at flexion. So this is important because this may affect the lateral tract. But in his series, he found that this survivorship was excellent, or good functional outcome with survivorship at 10 years about 100%, which is excellent. So this is one technique. Now, lateral epicondylar osteotomy. Anyone did that? Anyone did that? Okay. Usually you don't need, but if you do release of the iliotibial band, and you found that still the extension gap is tight laterally, and you test and found it tight on flexion, so you have tight flexion and extension gap laterally. So this indicates that the popliteus and the LCL are tight. So now either you go for sequential release and bypassing, or if the mismatch is big, like you may injure the ligament and you till you have matching. So what would you do? So for these severe cases with fixed valgus deformity, this is an option to do lateral condylar osteotomy to keep the ligament, not to jeopardize the ligament. And so this can be effective. And this is a more advanced technique using even navigation to do that, and this is the Mallogy who make the modified classification, and he found excellent results when doing that. Now, what about the bunkers? Do mechanical or kinematic? So the standard, most of you go with the standard mechanical, and this is important because if you do that, you have to make attention to the bonus lateral. So,
2 minutes.
Look here, if you do the cut like this, what's the problem? You will have more medial cut, and you will have very big mismatch between the medial and lateral, and you will need extensive release, and this may lead you to using a constraint. So in this case, imagine like what we do, like here, the kinematic, and I think our colleague told about us. If you do kinematic, then you have less lateral release, and you need no bone augment because it's bone preserving, but still there is a marked valgus deformity. So is this important? Does this affect the longevity of the implant? This is under investigation. But what's good with this technique that you have a normal kinematics like a native knee, and it have more functional outcome and also patient satisfaction. So here, what about this? Like in the middle, not mechanical, not kinematic, which is we call restricted kinematic. We make the cut, make the 2 mm for cartilage wear, so the medial side touching the medial condyle or the lateral jig doesn't touch the lateral condyle, 2 mm. And in this, which is restricted, we do some overcorrection, maybe 2 or 3 mm. And this again, less than the mechanical alignment and the soft tissue release. And there is still residual valgus, but it's less than if you use mechanical. So what I did in this, actually, I did this restricted kinematic, Yes, there is residual valgus, but we preserve the bone and also preserve the ligament. So in this, if you see, it was correctable deformity. We used no bony augments. The tibial cut was minimal, and the knee was very well balanced. So this is the patient only 4 weeks, and you see how is the function and even the patient's satisfaction. She feels like she has normal knee. This is another case, and you see it's like a puzzle. In this case, the mechanical and kinematic can be restored at the same time. How? Because this is the message, we have to analyze the whole deformity, because in this case, you see there is severe valgus by X-ray, but you see by the photo, by the picture, it's not. And when we analyze the deformity, you see the anatomy, the mechanical lateral distal femoral angle is normal, it's 88, while the anatomic is 75, so we have 6 degrees variation from normal. And this is from where it comes? Look here, it's a diaphyseal deformity. So in this case, we make our equation and we decided to go for 10 millimeter cut. And this, you see, the bone defect was contributing to the deformity of the valgus. And we here got the jig on 10. And this is the result, very well aligned, mechanically and kinematically. So, in these cases, you should analyze the whole deformity, not the knee deformity. So this is very important. So let's go for checklist intro. You have to have the image template, your augments, you prepare everything, prepare for possibility to prepare osteotomy, and plan your sequential release, and also you should have the constrained implant available. So take home message, valgus knee is less common, but it's more difficult to treat than varus. Valgus knee usually associated with bony and soft tissue deformity, and the classification depends on what we have said, your clinical and logistical evaluation, the status, mainly the status of the MCL, and the degree of deformity. And also you need proper sequential release, constrained implant if there is significant bone deformity or bone loss, or if there is deficient MCL. And always think of the kinematic alignment, because it preserves the ligament, preserves the bone, and result in excellent functional outcome. Thank you.